Dr. Adalja, I was thunderstruck that Auckland looks for perfection. They have 33 new cases, 1.7 million people, and I'm going to dazzle you now, Amish. 2 times 10 to the minus 6%. Scientific notation we got to go to, folks. It's a teensy-weensy amount that's ill. How do you respond to their attempt to be perfect?
I don't think it's the right approach. I think that this is something that's popular in New Zealand, but it doesn't really justify what they do. Their level 3 and level 4 lockdowns are really borrowing from the Chinese playbook. And I don't think that the way that they're so blanket, they pick up so many activities that aren't leading to spread, that don't allow people to do things in a safer manner. For example, go outside or not have to wear a mask when they're outside, or even be able to get takeout dining when they're under level 4 lockdown. So I don't necessarily think what they've done is correct, but they are vociferous defenders of it, as I found out when you criticize them. But it is something that I think really needs to be examined, because it's not sustainable. And they have about 30% of their population fully vaccinated. That's not a lot. Their rates are going up. But I don't think we need to do this in the post-vaccine era. And also, we've got rapid tests. We've got so much technology to allow people to do things safely that this abstinence-only approach, even if it's popular, shouldn't be what's done, and definitely shouldn't be enforced with police the way they do in New Zealand.
I don't sense it in America, but maybe I'm uninformed. Do we have elements of New Zealand from sea to shining sea?
We don't. We've had some aspects of it. For example, when you look at California, which had a very strict restriction on indoor dining or in outdoor dining as well, and you still saw cases really going up in California, because what that was doing, that abstinence-only approach in California, was driving behavior underground where it was more risky. And I think the lesson from this pandemic is that harm reduction, something that we do with HIV, with sexually transmitted infections, that's the way we want to approach public health, with voluntary means, trying to give people tools to make better risk calculations, knowing we're never going to get cases to zero, that there's going to be a baseline number of cases, hospitalizations, and deaths, but just trying to keep our hospitals from going into crisis. And I think we should have been doing that back from January of 2020. And I don't think that the U.S. is the good example here. I think they're both false alternatives, New Zealand and the United States, and there is a better way, a way like countries like Taiwan follow.
Dr. Adalja, in the meantime, the debate over booster shots continues to heat up, and just on a rival network, Dr. Fauci has been speaking, and he's saying that he does expect the FDA to decide to give boosters. Meanwhile, several FDA members have resigned, saying that it's unnecessary or perhaps scientifically unbacked. Where do you fit into this in terms of the need or lack thereof of boosters?
To me, the threshold for needing a booster would be someone that's fully vaccinated, getting a breakthrough infection that lands them in the hospital. That's just not happening. There's definitely probably going to be some need for boosters down the road, but I don't think it's going to be on September 20th or 6 months or 8 months post your second dose. It's something we need to be proactive about, but I don't think we're ready to pull the trigger for healthy people. There may be an argument to be made for the elderly, people in nursing homes, but that also needs to be driven by clinical data, not just looking at antibody levels coming down, but actually seeing, do people get severe infections this many months out from their vaccination? And does a third dose not only boost their antibodies, but does it actually protect them against that? So we want clinical data. We want this to be driven by the usual process of the CDC, the FDA, and all of that data being published so that people can actually look through it and sift through it, not something that's primarily being announced by the White House that's triggering people at the FDA to announce their retirement and to write in medical journals opposing it.
Dr. Adalja, what's the potential concern here about giving boosters? Is there any scientific evidence of harm, or that it doesn't really affect things at all? Or is it simply a matter of distribution of vaccine and trying to get unvaccinated vaccinated throughout the world as quickly as possible?
There's probably not a major harm signal, but again, if you read what the FDA, the departing FDA members wrote, they're worried about side effects that might occur if that third dose is too close to the second dose, or what that might do to the reactogenicity of the vaccine. But again, this is something that can be solved and answered with clinical data, just to look and see what happens to people who get a third dose. And that's what's really missing, or at least hasn't been presented publicly yet. And that's why I think that you've seen such a backlash against this plan from the infectious disease community, with a few notable exceptions. But in general, most of us don't think for healthy people that we're ready to recommend boosters in the absence of data. And it's important to remember what's happening in the United States with the number of hospitalizations and worries about crisis in places like Idaho and Kentucky. That's not going to be solved by third doses. It's first and second doses that solve that. And I think that's where the focus needs to be. And I think that we can prepare for boosters, get ready, but make sure that we do this right so that people have confidence that the process actually was scientifically driven and not driven by any other considerations.